Hello, this is Cindy. I wanted to introduce you to some of the annotations that are in the Codebook today and how they relate to reimbursement for medical care. Many of you are probably too young to remember reimbursement before the prospective payment system, but this is how we're paid now in the different hospital and ambulatory settings. In hospital we use inpatient PPS, and the ICD-10-CM and PCS directly impacts how we are paid. We're going to touch on the importance of the selection of the principal diagnosis that really drives your DRG. A DRG is a diagnosis-related group, is what DRG stands for. DRGs determine payment. You're going to see little symbols in your codebook for MCC, CC, which are major complication comorbidity and complication comorbidity. PDX-CC is a principal diagnosis complication comorbidity, and PDX-MCC is principal diagnosis major complication comorbidity. There's something called a present on admission indicator that has to be assigned for each diagnosis when the patient comes into the hospital. There are things called hospital acquired conditions that are what they sound like, diagnoses that are acquired while the patient is in the hospital, and this can affect reimbursement. And there's something called an HCC, or Hierarchical Condition Category. We'll talk about that. That is data that's mandated by CMS to be collected that helps determine their payment through their Medicare Advantage plans. We'll talk more about that. All of these things, these different symbols in your codebook, are explained in more detail in the codebook. So right now I'm going to go to the document camera and just show you a couple of things. Okay, we're in the codebook on the page where it says how to use the codebook. And if you're not using Optum, I'm sure you've got something similar to this in yours, so just give it a look there. In this section, it talks about the different appendices, which I will be touching on in this lecture. Then there's an overview of your conventions here. And then you get to additional annotations, which is what I'm talking about today, the different symbols and what they might mean to you. On the second page here, you see hospital acquired conditions, the CC condition, the MCC condition. Each one of them, you see the little symbols there. The CC excludes notation, which I will not be covering in this video. Over on this page you have the principal diagnosis CC and principal diagnosis MCC, and here's the little symbols for that. Medicare Advantage risk adjustment edits are talked about here, and that encompasses the HCC, is talked about here. Here's some more code level and some footnotes. So while you're reading all of these guidelines, don't forget to read about the annotations. The next page is where you actually begin the official guidelines for coding and reporting. The hierarchy of guidance. The conventions are first, and then the coding guidelines, and then the coding clinic. So whenever you're confused about if you're getting different directions from different things, this is the hierarchy here. So just helps me keep this in my notes. As I said, it's right here, but I wrote it in bigger letters to help me remember that hierarchy. It doesn't often come up, but occasionally it does come up where I'll see a guideline being a little bit different from what I have read in the coding clinic. Okay, let's get back to our PowerPoint. We're going to review the code sets that are used in different healthcare settings. There's inpatient, there's outpatient, there's ambulatory surgery, and there's physician office. We're going to look at the importance of the correct code assignment, because that then determines your MSDRG assignment, and the MSDRG assignment then determines your payment. We're going to understand the importance of recognizing an MCC or CC or neither one when you're looking at the list of codes there for the patient. The correct assignment could affect your reimbursement. And then a little bit later, we'll look at the importance of the present on admission indicators and hospital acquired conditions. All healthcare settings use ICD-10-CM for your diagnosis reporting. That diagnosis is what establishes medical necessity. So in order for insurance companies to pay for procedures, medical necessity has to be established. And in our system, ICD-10-CM is what does that. HIPAA mandates what standards are used for what in healthcare reimbursement. ICD-10-CM is used across the board for all healthcare settings for diagnosis reporting, but when it comes to procedures, ICD-10-PCS is the standard for hospitals reporting inpatient surgery and inpatient procedures, and CPT and HCPCS Level 2 are the standards for hospital reporting of outpatient procedures and physician office and non-hospital services. So we do what we do because we're mandated to do that by HIPAA. This is a table that reviews what I just said in a little more detail. But it's important for you to understand why you take the courses you take and why you're learning what you're learning. Medical necessity, as I said, is established by your diagnosis, which we use ICD-10-CM to assign our diagnosis. PCS are our procedure codes for inpatient, CPT, procedure codes for outpatient. HCPCS are more like supplies. But you can see here the way reimbursement is determined. I won't spend any more time on this, but you can at least review this slide and other slides to help you understand that. Under inpatient PPS, each admission is categorized into one DRG. Your DRG is determined by several things: your principal diagnosis, your secondary diagnoses, any surgery or procedures, the gender of the patient, and the discharge status. Looking back up at secondary diagnosis, that can be a complication or a comorbidity, which is a CC, or a major complication comorbidity, which is an MCC, or neither one. When you are looking to assign a secondary diagnosis, you're going to look at Section 3 in your guidelines, which is reporting additional diagnoses in the coding guidelines. That you don't code every diagnosis a patient carries with them. But if the diagnosis you have coded is being addressed during the hospital stay, then you are going to code that. Let me show you, using the document camera, where this is in your codebook. This is Section 3. This is reporting additional diagnoses, and these are the criteria that you as a coder are looking at to see if a diagnosis should be included. So if this diagnosis is requiring a clinical evaluation, therapeutic treatment, a procedure, is extending the hospital stay, or the nurses need to monitor this condition, any of those things qualifies a diagnosis to be listed as a secondary diagnosis. The UHDDS is mentioned here, and this is specific to inpatient, so that you know. And then in the guidelines it goes through more detail for how you look at those things. In addition to this, you see at the bottom where it says discharge status, that is the setting the patient is being discharged to, like home or skilled nursing, assisted living, whatever, and whether the patient expired, because certain CC and MCC annotations cannot be assigned if the patient doesn't survive the hospital stay. So you may ask, how is that DRG relative weight determined? When the DRG system was being developed, hospitals were looking at what services they provided, how many days a patient was in the hospital, and they also looked more closely at the patient's use of hospital resources. Now, not every patient is going to use the same amount of hospital resources, but it's not unusual for every patient with the same diagnosis to use similar hospital resources. So the DRG system looks at the estimated use of hospital resources when they determine the relative weight. Higher weighted DRGs reflect the knowledge that a more severe condition is going to require more resources than a less severe condition. When you hear the term case mix, just think about complexity. A case mix index is a single number that's used to compare the overall complexity of all the patients to the complexity of the average of all hospitals. So that's a little bit wordy, but you will hear that term, and just think about how it relates to complexity. A high case mix means you've got a high complexity of patient involved. Those patients have longer lengths of stay, so they're going to consume more resources, right? They have larger medical records that are going to take longer to code, and they're usually referred to as high dollar charts because they, being the higher complexity patients, are going to be more money for the hospital. And those are usually pushed to the beginning of the coding queue when a coder is sitting down to look at what he or she has to code. And they are coded all during the hospital stay instead of waiting until the patient is discharged. Each hospital has a PPS rate, and that is defined as a payment for a 1.0 value of service. When the DRG is assigned, that DRG has a relative weight. That relative weight is multiplied times the hospital's PPS rate to give the hospital a good idea of what their reimbursement is going to be. Those relative weights can also be called values. They are published in the Federal Register, and they can change every year. And there's so many of them you can't really memorize them anyway. But this just gives you an idea of the logic behind what is going on when the grouper is being used to assign the DRG. I'll talk about that in a different video about the DRG grouper, about the encoder, computer assisted coding, all those things. That'll be a different video for us. Here's an example using the 2017 MSDRG list. In this example, your principal diagnosis is an umbilical hernia without obstruction or gangrene. Pretty straightforward. No secondary diagnoses. And the principal procedure in this case is the umbilical hernia repair. Then I've told you there in the narrative, Ms. Patterson is a 16-year-old admitted to Community General Hospital to repair an umbilical hernia without obstruction or gangrene. She has no contributing MCC or CCs. And the diagnosis for umbilical hernia without obstruction or gangrene is K42.9. In 2017, the procedure to repair that hernia without a CC or an MCC fell under DRG 355, which they have titled Hernia Procedures Except Inguinal and Femoral. The umbilical hernia falls in this group. Hernia procedures except inguinal and femoral without CC and MCC. That DRG 355 has a relative weight of 1.2698. Community General Hospital's PPS rate is $4,000 for a 1.0 value of service. To calculate the reimbursement for this particular stay, we would multiply the relative weight 1.2698 times the hospital's PPS rate, which is $4,000, and that gives us $5,079.20. That's going to be the hospital's reimbursement for this stay. Now here's another one, and on this case I'm showing you this because I want you to understand how important it is if a coder misses a secondary diagnosis. Mr. Jones is a 76-year-old gentleman admitted to Community General with loosening of his right hip joint prosthesis. This is a complication of a joint replacement. He will have surgery for revision of the right hip prosthesis. The admitting diagnosis is complication of hip joint prosthesis, mechanical loosening. The code for that is T84.030A. You'll understand that code and that A later on. The coder did not code any contributing MCC or CC conditions. In 2017, the procedure for revision of a hip or a knee replacement without CC or MCC is DRG 468 and had a relative weight of 2.7936. Community General Hospital's PPS rate was $4,000 for a 1.0 value of service. So to calculate the hospital's reimbursement, you multiply 2.7936 times 4,000. That gives you $11,174.40. That is payment for this stay. In the third bullet point, you see the coder missed the fact that Mr. Jones also has a diagnosis of chronic gastric ulcer with hemorrhage, which is an MCC and should be coded as a secondary diagnosis. The code for chronic gastric ulcer with hemorrhage is K25.4. I'm going to show you that on the document camera. And because this is an MCC and because it will need monitoring during his stay, it should be listed as a secondary diagnosis. We're in the codebook. K25 is the category. We know that this patient had a chronic gastric ulcer with hemorrhage. You see right here, this little MCC, that's what I'm referring to. This diagnosis, K25.4, is an MCC. Later on, when we're learning more about finding a code, you're going to be looking at what this diagnosis includes. If the patient had any alcohol abuse, you would code that. Our narrative doesn't mention that, so we don't have to, this is called an instructional note. We don't have to listen to that in this case. The excludes notes we'll talk about later. The main thing I want you to see for this is the chronic gastric ulcer with hemorrhage is an MCC. So now, if we go back and code it using the secondary diagnosis of chronic gastric ulcer with hemorrhage, when you look at the second bullet point, you can see that it's now DRG 466. It has a much higher relative weight. So when you multiply 5.0249 times the PPS rate for Community General Hospital, you get $20,099.60. This table is comparing those two scenarios where the coder was incorrect in just picking up the principal but not the secondary, which led to a reimbursement of $11,174. The correct diagnosis was the principal and the secondary diagnosis, which is an MCC, placing the patient in a different DRG with a different relative weight, much higher, really twice as high, and giving you a much higher reimbursement. This is one of the reasons why many hospitals have gone to computer-assisted coding. Computer-assisted coding catches some of these things that a coder might miss when the computer is analyzing the chart. The next thing I want to talk about is Appendix H in your codebook, Present on Admission tutorial. Be sure you go through that. I'm not going to take the time on this slide to go through it. I will be reviewing it in general, but for you to understand the importance of that, a Present on Admission indicator. A POA indicator is an indicator that's assigned if the condition is present at the time the order for inpatient admission occurs. That's a yes on your POA indicator. That condition can develop during an outpatient encounter, like in the emergency department, outpatient surgery, all those things. That's counted as a yes for your POA indicator. The time frame that you're really looking at is at the time the order for inpatient admission occurs. This is important that you know which conditions were present on admission, because if a condition develops during hospitalization and that condition is designated as a hospital-acquired condition, then it's going to affect your reimbursement. Then I go through some more details there. As always, your documentation is critical. Appendix I talks about your hospital-acquired conditions. Be sure you look at that in your codebook. Hospital-acquired conditions came out of the Deficit Reduction Act of 2005, where conditions were identified that were either high cost, high volume, or both. And because of that condition, a higher severity DRG was assigned. And the whole idea behind the HACs is that they could have been prevented if the patient had received care that was based on evidence-based guidelines. So the powers that be chose 14 categories to look at as HACs. A lot of them make sense. A foreign object retained after surgery. That's something is left in the body after surgery. An air embolism, the wrong blood was given to a patient. Stage 3 and Stage 4 pressure ulcers. That is important because if a patient comes in with no ulcer or a Stage 2 ulcer and it progresses to Stage 3 or 4, that indicates that the correct care has not been provided for that patient according to these guidelines. Any falls and trauma in the hospital while in the hospital. Poor glycemic control would be diabetics that either bottom out or have excessively high sugars because they're not being monitored correctly. urinary tract infections that the patient gets from having a Foley catheter, for example, for too long of a period according to these guidelines. A vascular catheter are like central lines that go into the body. Surgical site infections are important for lots of reasons, and they're listed there. The CABG is when you're grafting coronary arteries. Bariatric surgeries like bypass, gastric bypass. Certain orthopedic procedures like if you get an infection after you've had a joint replacement. And then the infection following the cardiac devices. A DVT or pulmonary embolism following orthopedic procedures like joint replacement. All these things are considered hospital acquired because if the patient had received the proper care, they would not have gotten these conditions. The way it works is if one of those conditions is recognized by Medicare as a hospital acquired condition, and that hospital acquired condition is the only CC or MCC on the patient's chart, the patient cannot be assigned to the higher weighted MSDRG. In other words, you're not going to get the money for a higher weighted MSDRG if the reason why you're being kicked into a higher paying DRG is because of these conditions that were acquired during the hospital stay. Hopefully that makes sense. Here's some examples. You've got a patient admitted with a principal diagnosis of acute inferior MI initial episode. MI is a myocardial infarction. And also has a secondary diagnosis of arteriosclerotic coronary artery disease. You see the POA indicators. They're in the fourth column. Yes, she came in with the MI. Yes, she came in with the coronary artery disease. But during her stay, she developed a stage 3 pressure ulcer of her right hip. That is an L89.213 diagnosis. It is a major complication comorbidity, and it is a hospital-acquired condition. Why is that important? If you look down at the DRGs that would be applicable in this case, if she's looking at being discharged alive, which is significant when you've had an MI, and you have no CC or MCC, your relative weight is 0.7463. But if you have an MCC, which she does now have because of her pressure ulcer, if it were not acquired during the hospital stay, it would kick her into the DRG that pays 1.6748 times the PPS rate. But you're not eligible as a hospital for that higher severity DRG because it was a hospital acquired condition. Important that the correct POA indicator is assigned with each diagnosis when the patient comes into the hospital, and those hospital acquired conditions are identified, and look how it impacts the DRG. Appendix J is the HCCs, which I talked about a little bit earlier. These are hierarchical condition categories. The risk adjustment model is explained there in a little more detail that I'm going to go into. Basically, it was begun in 2004, and it's a way for CMS to capture information on 70 HCC categories. It's called a hierarchy because some categories override other categories, and in that case you're going to choose by your hierarchy which you're going to report. And why does CMS collect this data? Because diagnoses from the previous year are used to establish capitation payments to the Medicare Advantage plan, which some of you may recognize as one of the what's that called? Managed care plans under Medicare. That HCC has to be captured every 12 months for CMS to reimburse the docs in that MA plan. It all boils down to data collection, and it goes back to the physician's office to document their encounters. If the doctor doesn't document these things the right way and collect this data for CMS, they're not going to be paid as much as they should be paid if they had done so. There are coders that this is all they code, or HCCs. I'm not going to talk about it anymore in this course other than what I just said, so that you know what it is, and if you ever have a job doing that, you'll know why you're collecting that data. There's lots of HCCs, but I'm only going to look at the few that are very common here, and that would be diabetes, COPD, congestive heart failure, breast cancer, ischemic heart disease, and angina. Those 6 are very common for the doctors in the Medicare Advantage plan to be documenting in the patient's chart. What I wanted to show you here, this is a screenshot of that T84 diagnosis we looked at earlier for the gentleman who had the joint loosening. And what I wanted to show you is, you see these T84 are all HCCs. Those are things that have to be covered by the doctor in the MA plan, Medicare Advantage plan, to report to CMS, because they're going to be looking at that when they're determining payment. In conclusion, I know this is a lot of information, but I hope it helps you better understand some of these additional annotations in your codebook. I mentioned in the first bullet point, coders have a legal and a fiscal responsibility to code accurately. It directly impacts reimbursement for these facilities. The inclusion of computer-assisted coding has greatly enhanced facilities' ability to recoup the money that they should be paid. Where coders are going to come into play as this computer-assisted coding gets smarter and smarter, coders are going to be looking more at auditing things than assigning codes the way we do now. I'll talk a lot more about that in a different video, but just so you understand that the codes that you are assigning are directly related to how much reimbursement the hospital is going to get. The second bullet point talks about if you want to be a coder, you're going to have to stay on top of everything. I am on YouTube almost daily, looking at medical advances, reviewing coding guidelines, reading the coding clinic, which you will have access to when you're in a facility or hospital, and any changes to federal regulations, because that does directly impact reimbursement, and that's your job as a coder. You are assigning codes so that the hospital can be paid through the inpatient prospective payment system what it's due for the care of that patient. If you have any questions, please post them in the discussion board, and I'll be glad to talk about them. Thank you very much, and have a good day.